Now the first question which we asked you, and it is a very important question for your NEET PG, is that you will be given always a child with nephritic syndrome. So what is nephritic syndrome? A child who has hematuria, which can be gross or microscopic, hypertension and edema. Okay, so this is a nephritic syndrome. So I'll again repeat: hematuria, hypertension and edema, with his creatinine is also slightly on the higher side. So that's a nephritic syndrome. And in fact the question is easy. Any child with nephritic syndrome, the most common nephritic syndrome in the developing world will be post-streptococcal. But remember, all of you, in your exams you will also be given a child who has a rapidly progressive glomerulonephritis. Now what is RPGN? It means a child who has the same triad of hematuria, edema, hypertension, and in addition there is a rapid loss of kidney function, which means that there is loss of kidney function over the next days to weeks. So remember, this is days to weeks and there is a kidney failure. And most of the times when we say GN, rapidly progressive glomerulonephritis, you will find that these children will have crescents on the biopsy. What are crescents? Proliferation of the parietal epithelial cells. Now remember, very important for your exams, remember the immune complex, especially the post-streptococcal, is the most common. Okay, so there are many other infections which can cause glomerulonephritis, but this immune complex is the most common. Then there are some other forms like infective endocarditis, shunt nephritis, hepatitis B, C, lupus, Haynor-Schönlein purpura, IgE nephropathy. So all of these will have some immune complexes, and on the immunofluorescence also you will see deposits. Now second comes posi-immune crescentic GN, and in fact in your NEET PG they once asked you which is the most common posi-immune crescentic GN. Remember, microscopic polyangiitis is the most common posi-immune crescentic GN in children. Now when we say Wegener's also has pulmonary hemorrhage, and so is anti-GBM, which is the good passer syndrome, which also has pulmonary hemorrhage. Now as you can see here, so based on the immunofluorescence, if you see immune complexes or there are no complexes or there's a linear deposits of IgG and C3, that's anti-GBM, which is also called good passer syndrome. So please remember, in your exams you will definitely have one question on crescents. So here you can see on your right side cellular crescents, and in the middle you can see some fibrocellular crescents in a child with rapidly progressive glomerulonephritis. So remember, post-streptococcal glomerulonephritis is the most common cause of GN and also the most common cause of rapidly progressive glomerulonephritis. Now the second question which I asked you, and is again a very important question for your all exams, whether it's AIIMS exam or NEET PG exam, it is on neonatal resuscitation. So all of you need to remember that in 2015 the guidelines for neonatal resuscitation have changed. So I will be talking to you about what are the new guidelines which have changed in 2015. Now first, what has changed is that in every baby, whenever a baby is born, you need to do pulse oximetry. Okay, so that's new from 2015. And in your last year's NEET PG, they asked you which limb is preductal. Remember, right upper limb is preductal. Okay, now left limb is, so as you can see, this is your aorta, pulmonary artery, ductus. So right hand is mostly supplied by a branch of aorta before the ductus arteriosus. Okay, left is indeterminate and the lower limbs are postductal. So all of you, whenever a baby is born, we keep a pulse ox on the right upper limb and the lower limb and we compare. Now there are some targets which all of you need to remember. At 1 minute, the target of right upper limb preductal is 60 to 65%. At 2 minutes, it's 65 to 70%. At 3 minutes, it's 70 to 75%, which came in NEET PG. 4 minutes, 75 to 80%. 5 minutes, 80 to 85%. 10 minutes, 85 to 90%. Remember that. Now, the new guidelines talk about whenever a baby is born, all of you, you need to ask yourself 3 questions. Term, tone, cry. So if the answer is yes, the baby goes to mother. If the answer is no, then you do TABC. TABC. So remember, temperature always comes first. Then you look at the airway, breathing and circulation. Okay. So remember, number 1. So if a baby is apneic or gasping, then you start positive pressure ventilation. Okay. So if a child is in apnea or gasping, you start positive pressure ventilation. As you can see here, you start positive pressure ventilation. And along with that, now you need to keep a pulse ox and consider ECG monitoring. So that's our question. All of you, I'll go back to the question which I asked you. The question was, after the first step of resuscitation, if heart rate is less than 100, what is not done? So all of you, CPAP is not done. I'll again show you. Here. So after the initial steps, first we said the first indication of bag and mask ventilation is apnea or gasping after the initial steps. Now the second indication, as you can see here, of bag and mask ventilation is heart rate is below 100 per minute after the initial steps. So if heart rate is below 100, you consider positive pressure ventilation, use a pulse ox, consider ECG monitoring. So all of you, this whole table is important. I'll read it with you. Now if heart rate is still low, now before going on to that, remember this question came in your AIIMS exam also. What is the best indicator for adequacy of ventilation? Improvement in the heart rate. So if your heart rate is improving, your ventilation is fine. But if your heart rate is still low, then you check the chest movement, the chest rise. You do some ventilatory corrective steps if required. You may need to look for endotracheal tube if needed. Now if heart rate is still below 60, now that's an indication for intubation. Now I'll repeat this because this has not come in your exam, but this is likely to come in your exam. So remember, if heart rate is still below 60, that's an indication for chest compressions. Intubate if not done till now. 100% oxygen. Now is the time to add 100% oxygen. ECG monitoring, and consider emergency umbilical venous catheter placement. Okay, on your right side, if there's just labored breathing or central cyanosis, you may give oxygen if needed. You consider CPAP, position the airway. Okay, so that's very important, friends, very important for your exam. Okay, each and every box is important. Now the next question we have is a baby who presented with respiratory failure. Mother had anhydramnios, so there was no amniotic fluid, and this baby has large kidneys with multiple cysts. So remember all of you, the amniotic fluid of the mother after 20 weeks of gestation is mostly child's urine. So after 20 weeks of gestation, the amniotic fluid of the mother is mostly child's urine. So this means that this child has bilateral non-functional kidneys. Now remember, most commonly that cause will be looking at here, you have large cysts in both the kidneys. So this looks like a bilateral multicystic dysplastic kidney. Now remember, even in AIPKD you have large kidneys, but these are multiple small cysts. Okay, so there are multiple small cysts. They are not large cysts, multiple small cysts which are not easily seen on ultrasound. They are seen on CT scan. Now AIPKD usually has irregular large kidneys with multiple different sizes. So remember, dominant disorders present late. AIPKD presents early. Now posterior urethral valve will usually present with both kidneys showing hydronephrosis and dilated ureters, a thick walled bladder. So there's a valve here. Okay, so remember, posterior urethral valves will classically present with bilateral hydroureteronephrosis and a thick walled bladder. Meckel-Gruber syndrome is a rare syndrome in which you have cystic kidney disease. This child doesn't have a syndromic association here. So this is bilateral multicystic dysplastic kidney, which is rare. So remember, multicystic dysplastic kidney is mostly unilateral. Rarely it's bilateral, which presents like a Potter's. So all of you should remember, so if you have a child who has severe problems like this, then this child is born like a Potter's sequence. So all of you, I'll just show you a child who looks like Potter's here. So let me see if I have a photograph of Potter's sequence here. So here is a photograph of a child with Potter's. So any cause of bilateral non-functional kidneys. So if both kidneys are not functioning from in utero, these children have a very flat face, as you can see here. He has a very flat face. So because there was no space in the mother's amniotic cavity, so he's a very flat face, a bird-like face with a small chin. So this is the classic Potter's facies. Okay. Now remember, so Potter's sequence can be seen in any cause of bilateral non-functional kidneys. Any cause of bilateral non-functional kidneys will cause mother having anhydramnios. Now amniotic fluid of the mother is very important for a child's lung development. So this child now gets bilateral pulmonary hypoplasia. So now this child gets bilateral pulmonary hyperplasia. So remember, it's a triad and one thing leads to the other. Okay. So remember, amniotic fluid is very important for a child's lung development. Okay. So this is a child who will present to you with a typical Potter's sequence. Now, which of the following inborn error is X-linked? So remember, OTC deficiency is in fact X-linked dominant. Out of this, rest other. So the question is X-linked recessive. So remember, I would say here that OTC is X-linked dominant. Leschnian is X-linked recessive. So you should know that the answer here should be Leschnian syndrome. It's X-linked recessive. OTC is X-linked dominant. Okay, rest are autosomal recessive. So that's very important. So you should know about some X-linked recessive disorders and also the X-linked dominant disorders. Okay, so let me talk to you about some X-linked recessive disorders which are very important. For example, in your last NEETPG, they asked you about a triad, okay, of eczema, thrombocytopenia and immunodeficiency. Okay, so Wiskott-Eldridge syndrome is X-linked recessive, a triad of eczema, thrombocytopenia and immunodeficiency. Chronic granulomatous disease is also X-linked recessive. Chronic granulomatous disease is X-linked recessive. Leschnian syndrome, so the answer to that question was actually Leschnian syndrome. Okay, then remember that you have other syndrome like Hunter syndrome is X-linked recessive. So these are very important syndromes which are metabolic. Then of course Duchenne's muscular dystrophy, the Becker's muscular dystrophy, Loewe syndrome, Dent disease, hemophilia, color blindness are all X-linked recessive. Coming to X-linked dominant disorders, remember Rett syndrome, okay, hypophosphatemic rickets, which is also called vitamin D resistant rickets, hypophosphatemic rickets. Then a very important disorder today which we are talking about, OTC deficiency. OTC deficiency is X-linked dominant. Remember, this is the most common urea cycle disorder, which is again severe in males. The most common urea cycle disorder. And in this, these males have high ammonia. Urine has orotic acid urea, urine orotic acid, which gives rise to urine uracil. So remember, urine orotic acid is a precursor of urine uracil. That's very important. Okay, another syndrome Aicardi syndrome is also X-linked dominant. All of these disorders are severe in males. All of them are severe in males. And remember, the first two disorders, Rett's and incontinentia, are so severe in males that these two syndromes are lethal in male fetuses. Only females are born. Males die in utero. Okay, so the answer to this question would be a Lesch-Nyhan syndrome, which is X-linked recessive. The question was X-linked recessive disorder. Okay, remember Hurler is autosomal recessive and Hunter is X-linked recessive. Okay, now the next question is which is the best investigation for scarring? So remember, a DMSA nuclear scan is the best scan for looking at scarring, while MAC3 is the best scan for function of kidneys. That's a nuclear scan. So remember, MAC3 is the best scan for function of the kidneys, followed by DTPA. Now DMSA is a scan for renal scarring. Okay, we are talking about that in children, the most common cause of UTI, especially in children, is vesico-ureteric reflux. So there are some children, when they pass the urine, what happens is the urine tends to reflux back to the upper kidneys. That's called VUR, vesico-ureteric reflux. Now because of this reflux, the scars which happen are typically at the poles of the kidneys, the upper pole and the lower pole. Now DMSA is the best scan to look for these polar scars which we see in children with recurrent UTI. Now the next question was on a torch infection. Which infection can cause cataract and a heart murmur with a rash? So remember, blueberry muffin rash is not a very specific rash. It occurs in many torch infections, but cataract and heart murmur are classically seen in congenital rubella syndrome. So remember, rubella is a triad of heart disease. Okay, then rubella can also have microcephaly, mental retardation, and cataract, and rubella has cataract. Okay, now in the heart, all of you remember, rubella has PDA followed by peripheral pulmonary stenosis. They can also have a VSD. Okay, remember ASD is rare in rubella, so that's most common. PDA, peripheral pulmonary stenosis, VSD, ASD is rare in rubella. Okay, coming to the next question. So here I would say rubella. Now how do you differentiate the other ones, CMV and toxoplasma? Now remember, parvovirus here down below is one of the cause of non-immune hydrops fetalis. So if they ask you, this question came in last year's NEETPG, can you tell us any infection in the mother which can cause non-immune hydrops fetalis in the baby? Parvovirus. Now how do you differentiate CMV from toxoplasma? So remember, all of you, how can we, I'll show you a CT scan comparing CMV with toxoplasma. Now remember, both of them have intracranial calcifications. Both CMV and toxoplasmosis have intracranial calcifications. But remember that CMV has periventricular calcifications. So on your right side, you can see periventricular calcifications which can cause seizures. Now remember, CMV typical has cortical atrophy of the brain. So this child will have microcephaly, a small head. He will have microcephaly, cortical atrophy of the brain. Okay. Now on the other hand, toxoplasmosis, the calcifications in the brain typically occur in the basal ganglia, choroid plexus, caudate nucleus, choroid plexus and caudate nucleus. So they will be in the center, as you can see here. Now remember, the calcifications in toxoplasmosis block the aqueduct. They block the aqueduct. So remember, hydrocephalus is a classic feature of toxoplasmosis because the calcifications which are seen in toxo, they block the aqueduct. So please remember that. So CMV has a small head, toxoplasmosis has a large head with hydrocephalus. Okay. Now here you have a child with polyuria, polydipsia, with a normal sodium potassium. Serum osmolality is on the higher side. Sodium is very high, in fact this child has. Sodium is high and urine is dilute. What will you think of? So let me take you to what should be the approach whenever you have a child with polyuria and polydipsia. So remember, whenever I say polyuria, it means that this child's urine output is more than 4 to 5 ml per kg per hour. His urine output is more than 4 to 5 ml per kg per hour. So first of all, you need to look at blood sugar. Now, all of you know a random blood sugar more than 200 milligrams per deciliter and a fasting blood sugar more than 126 milligrams per deciliter is called diabetes mellitus. Now, if diabetes is not there, your next step will be to get a blood gas, a venous blood gas, and to look at sodium and potassium. Okay, that's your next step, to look at venous blood gas and to look at sodium and potassium. Now all of you can have three possibilities. So what we'll do is we'll talk about first possibility of hypokalemic, hypochloremic, metabolic alkalosis. So remember, classically hypokalemic, hypochloremic, metabolic alkalosis is seen in Bartter syndrome. Okay, it is seen in Bartter syndrome, followed by Gitelman syndrome. Okay, so remember, this is seen in Bartter syndrome, followed by Gitelman syndrome. So how do we differentiate Bartters from Gitelmans, all of you? So we differentiate Bartters from Gitelmans by the severity. Remember, Bartter syndrome is severe, presents early within the first year of life. Gitelman's is mild, which presents later in life. Bartter is severe, presents early in infants with failure to thrive, while Gitelman's is a well-thriving child. Gitelman's has two things, remember, hypomagnesemia and hypocalciuria. Okay, so remember, Gitelman's has hypomagnesemia and less calcium excretion, while Bartter has hypercalciuria. This is very important, all of you. Remember, Bartter syndrome has hypercalciuria. Okay, so they may have nephrocalcinosis in the kidney. Now the second condition here can be hypokalemic, hyperchloremic, normal anion gap metabolic acidosis. Remember, which is hypokalemic, hyperchloremic, normal anion gap metabolic acidosis, which is called renal tubular acidosis. Okay, RTA. Now remember, renal tubular acidosis can be proximal or distal. Now the third situation here is that all of this is normal. Now when all of this is normal, your options are either this is psychogenic or diabetes insipidus. So when all of this is normal, you should think about whether it is psychogenic. So all of them will have, if someone is drinking a lot of water, psychogenic, sodium will be on the lower side and urine will be dilute. Now we can differentiate psychogenic from DI by a water deprivation test. Water deprivation. Now on water deprivation, the urine will become concentrated in psychogenic because tubules are fine. So on water deprivation, the urine will become concentrated. The urine osmolality doubles. Now DI can be central or nephrogenic. Now that's a typical diabetes insipidus, in which your kidney tubules are not able to either absorb water, okay, because of a problem in the pituitary or a problem in the nephrons. There is end organ resistance. So it can be central or nephrogenic. So basically, since they are not able to absorb water, so your serum sodium will be usually more than 145 milliequivalents per liter. Okay, so serum osmolality is more than 300, and urine is dilute. So urine is lot of water, lot of free water. So urine osmolality is less than 300 milliosmoles per kg. So coming back to your question, here is a child who has a very dilute urine. Okay, his sodium is on the higher side. So I would say this serum osmolarity is not a very good question here, because it should be more than 300 in this child, but urine is completely dilute. So and moreover, it's a boy. Remember, nephrogenic diabetes insipidus is X-linked recessive. So very commonly we see boys with nephrogenic DI. There are some drugs also which can cause nephrogenic diabetes insipidus, like lithium and amphotericin B. Now this is the next question is a very important question for exams. I can bet every exam, every NEETPG will have a question on this. You have a child who comes to you with a salt wasting crisis and has hyperpigmentation of the genitalia. So remember, that's a classic CAH. That's a classic CAH. So all of you, please remember, in your exam you will definitely get a child with CAH. So mostly remember, CAH is the most common cause of a female pseudo-hermaphrodite. Child is a female, so it is autosomal recessive, so you can have a female or male. So it's the most common cause of a female pseudo-hermaphrodite. That question came in NEETPG 2018. Female who looks like a male, female pseudo-hermaphrodite. This question came in my NEETPG. What is this photograph showing? This photograph is showing a phallus. There are no testes. So this is basically ambiguous genitalia. Ambiguous genitalia. This phallus is actually a hypertrophic clitoris. So all of you remember that CAH, congenital adrenal hyperplasia, 90% of the times is a block here. This question also came in your last NEETPG. 90% is deficiency of 21 hydroxylase enzyme. Okay, so aldosterone is not formed, cortisol is not formed, and there is excess of testosterone. Okay, so aldosterone is not formed, cortisol is not formed, and there is excess of testosterone. So since aldosterone is not formed, sodium is lost, potassium is retained, and this child is in shock. So remember, 70% of CAH presents like this in a salt wasting crisis kind of fashion. Salt wasting crisis. This child may have hypoglycemia, not necessarily, but may have hypoglycemia, and testosterone is high. So because of the testosterone, these females may have hypertrophy of clitoris, and males may have precocious puberty. So males may have precocious puberty. Now remember, all over the world we diagnose this by accumulation of this compound 17-hydroxyprogesterone. So remember, this is a neonatal screen for CAH. All over the world, 17-hydroxyprogesterone is done to diagnose CAH. Now in your last NEETPG, they even asked you, how do you treat CAH? So we treat CAH by supplementing a mineralocorticoid, fludrocortisone, and a glucocorticoid, hydrocortisone. So treatment of CAH is to supplement glucocorticoid, fludrocortisone, and mineralocorticoid. So glucocorticoid is fludrocortisone. Mineralocorticoid is fludrocortisone, and glucocorticoid is hydrocortisone. So we give hydrocortisone with a mineralocorticoid. So this is a classic salt wasting crisis in a child. Okay. So this screen of 17-hydroxyprogesterone should be done in all newborns all over the world. Now here is another child who comes to you with precocious puberty and hypertension this time. So remember, according to the 2018 American Academy of Pediatrics guidelines, any adolescent more than 13 years If he has a blood pressure more than 130/80, that's hypertension. Okay, so adolescents more than 130/80 is hypertension. And remember 120/80, you must have heard about 120/80. 120/80 is always hypertension in children less than 10 years. This is hypertension grossly. So remember all of you, now let us look at some rare findings, some rare types of CAH. And now let's look at this deficiency, a rare variety of congenital adrenal hyperplasia, which is called 11-beta hydroxylase deficiency. Now what will happen? Again, you will say, sir, aldosterone is not formed, cortisol is not formed, testosterone is high. So you may have a child here with precocious puberty or virilization in females. But remember all of you, DOCA. This DOCA has an inherent mineralocorticoid activity. So remember, this DOCA has an inherent mineralocorticoid activity. So if you have something like aldosterone in your body, sodium is high, which leads to hypertension. Potassium is low. All of you know that aldosterone leads to sodium absorption and potassium excretion. So there is hypokalemic metabolic alkalosis. So all of you please remember this, that you will get in your exam, if you get a child with hypertension and hypokalemia, think about some problem related to CAH. Okay, that typically occurs in 11-beta and 17-alpha hydroxylase deficiency. So suppose I erase it for you. Suppose I erase. So I said number 1, hypertension is seen in 11-beta hydroxylase deficiency. Now let's look at 17-alpha. Now what will happen here? 17-alpha hydroxylase deficiency. So if there's a deficiency here, this is not formed, but aldosterone is high. Again, so in 17-alpha hydroxylase deficiency, you will have sodium retention, hypertension, potassium excretion, hypokalemia with metabolic alkalosis, no cortisol, low glucose. Now testosterone is not there, so here you may have a male who looks like a female because he has no testosterone. So this is a very rare variety of CAH in which you may have a male pseudo-hermaphrodite. Okay, so all of you, I told you a mnemonic in all of your classes. I'll again repeat it for you. So what you do is, in your copy, you can write MT. Okay, write MT. Now M, by M I mean mineralocorticoid, and by T I mean testosterone. Okay, just write MT. By T I mean testosterone. Now write 11, 17, 21. Now what does this mean? Everyone. 1 means, 1 is, can you see this 1? This 1 looks like an arrow here. So let's make an arrow here. So 1 means mineralocorticoid is high. So make this 1 like an arrow here. So all of you, this means that in 11 hydroxylase deficiency, both mineralocorticoid and testosterone are high. In 17, only mineralocorticoid is high. And in 21, only testosterone is high and mineralocorticoid is not. Okay, so in 21, they have a salt wasting crisis because the mineralocorticoid activity is not there. So just remember 11, 17, 21. Okay, so remember this mnemonic. So keep that in mind. So remember, so that was 11 beta hydroxylase deficiency. A child who has precocious puberty suddenly became tall because of the precocious pubertal spurt and is hypertensive. Now the last question I thought I'll ask you about is, how do you manage children with recurrent UTI? Now remember, today I told you that number one, the most common cause of recurrent UTI in children is VUR, vesico-ureteric reflux. So first of all, let me tell you that now we have some guidelines. All of you remember, now we have some guidelines for this. I'll just delete this. So we have a Indian Society of Pediatric Nephrology guidelines. So what those guidelines say is, any child who gets first UTI, okay, first urinary tract infection in a child less than 1 year, you have to do all 3 tests: an ultrasound, MCU. Remember, MCU is the investigation of choice to look for VUR. Okay, so remember, MCU is the investigation of choice for this VUR. I'll just show you a VUR here. Just 1 second, I am looking for this. Yeah, so this is an MCU showing different grades of VUR from grade 1 to, on your right side down below, a grossly dilated tortuous ureter. That's a grade 5 VUR. So MCU is the investigation of choice for looking at VUR, and DMSA for scars. Now between 1 to 5 years, we do ultrasound and a DMSA. Now if any of these is abnormal, we will do MCU. If any of ultrasound or DMSA is abnormal. Now more than 5 years, we only do ultrasound. And if ultrasound is abnormal, then we proceed to other tests in these children. So coming back to your question, the question was, now what will we do? Now before going on to this question, remember just two points. Just 2 points about vesico-ureteric reflux. First is, less than 1 year, any grade of VUR resolves. So remember, less than 1 year, we do not go for surgery, because as they grow, it improves. So that answers your question. So less than 1 year, we will not do a surgery, we'll just hold on and we'll just put them on antibiotic prophylaxis. And remember, the antibiotic prophylaxis of choice is cotrimoxazole here. Cotrimoxazole is the drug of choice for antibiotic prophylaxis. So remember, secondly, grade 1 and 2 VURs, grade 1-2 VUR, any age resolves. So if you have a small VUR, we will just hold on. We'll just put them on antibiotic prophylaxis. So remember, surgery, which you don't need to know actually, surgery is called a surgery where we reimplant the ureters. So surgery is only for bilateral high grade VURs. Bilateral grade 3 or more VURs, we may go for surgery. Okay, so nowadays more and more we go towards less of surgery, more of antibiotic prophylaxis. Okay, so these were very important topics which I feel will come in your exam. I am Dr. Siddharth Sethi, and all the best. You can find me on the Facebook on PDF for PG. I have a hashtag on the DAMS Club. You can find all of my posts with this hashtag. Thank you.